So you all know that amyloidosis is not a single disease, and we are not in an era to accept a diagnosis, just a pathology diagnosis of amyloidosis, because we know that this is not, that this actually presents a diverse group of systemic and local diseases, and that these deposits result in a wide range of clinical manifestations, as you've heard from both Professor Azazi and from Tamer, and these clinical manifestations actually depend about the type, location, and the amount of deposition. However, there is still considerable clinical overlap between all amyloidosis type. You've seen a lot of pictures of how amyloid fibers look like under electron microscopy. We all know that there are genetic factors which are involved, cofactors as amyloid P components, they do have a role, but there is always an unknown additional stimulus which is required to turn these proteins into this excess misfoldings and amyloid formation and deposits. You've seen in Professor Azazi's presentation the Congo red appearance, and that this is what we consider pathognomonic for diagnosis. I just want you to, I don't know if this pointer works. Okay, what we have on the right is a Congo red stain, and on the on the left is the Congo red stain, and the amyloid material is going to take this dark orange color. And on the left is how it looks like under polarized light. Let me show you a bigger picture. This is how amyloid looks. All amyloid types will give a similar histology, an identical histological look, with these amorphous deposits within glomeruli, arteries, arterioles, tubules, and interstitium. Not all of them, not all types of amyloidosis involve all compartments of the kidney, and this is how it looks under polarized light, and this is what is diagnostic. This is what's pathognomonic. It's not this color, it's the fact, as you've heard from Professor Barsoum, that this material is able to give this characteristic apple green birefringence. And because this is important, and one of also the methods that sometimes clinicians prefer is an abdominal fat pad biopsy or fat aspiration to confirm the presence of amyloidosis. This is important to know that also collagen stains red. So as you can see in on the picture on the left, that this is not amyloid, this is actually collagen. And unless it gives you this apple green birefringence on the right, this is amyloidosis. But look at the lower panel, you also have these orange fragments, but the birefringence is not apple green. It does polarize, it does give you a birefringence, but this birefringence is white, and this pattern is not, unfortunately, is not recognized by many pathologists, so it leads to a lot of overdiagnosis of amyloidosis just because it gives this birefringence under polarization. The birefringence should be restricted to this nice apple green color you see in the picture at the top. Abdominal fat biopsy could be very useful. We also do phenotyping on abdominal fat biopsies. This was from a patient with an AL-Amyloid, and this was a Lambda immunostaining. However, you have to know that the yield which you can get in diagnosis of an abdominal fat biopsy will depend on the type of amyloid, because as I said, types of amyloid also govern the site of deposits, and sometimes you need a deep biopsy to get the amyloid. And the second thing is that you really need abundant tissue. So a biopsy is preferred than just aspiration of fat. Always make sure that you can get a lot of fat if this is how you want to diagnose amyloid. However, as Professor Azazi mentioned, most of amyloid diagnosis is done via renal and liver biopsies in Egypt. There are other methods of detection of amyloidosis. However, they are much less specific and more complicated than Congo red. So Congo red remains the golden standard. As I am a renal pathologist, among being a pathologist also for surgical pathology. However, when it comes to amyloidosis, kidneys are always the target, and these highlighted in three are the commonest three types of amyloidosis which can involve the kidney, and also the commonest three types which are prevalent within our population, like serum amyloid A, AL, and ALAC2, as I'm going to show you. Yes, although they all all give the same similar histological pictures, but in a renal biopsy, we can guess which type it is because each type of them give a unique morphological feature and a different site of deposits. But in spite of this, that distribution pattern and morphology can give you a clue. It should not substitute for amyloid typing, but it can guide the typing process. How do we do amyloid typing? We do it by looking for antigens or antibodies against the antigenic proteins, whether by immunofluorescence or fresh non-formalin fixed tissue. This is a procedure which is not done in Egypt. We all use immunoperoxidase studies on formalin fixed paraffin embedded tissue, and other methods which are reported are mass spectrometry, immune electron microscopy, and amino acid sequence analysis, and I'll discuss some of them. When it comes to IP amyloid typing on formalin fixed tissue, which is the routine biopsy you take, we have commercially available immunohistochemistry antibodies against most amyloid type. At least the 3 commonest amyloid types are covered, which will include amyloid AA, AL, and ALACT. In these patients, you need to do the whole panel to avoid non-specific results and unnecessary backgrounds. So I just cannot stain a biopsy for amyloidosis for a single marker. The whole panel should be stained for. And if the cases are negative, then we need to do extra effort or consider referring them to larger centers. Why referring them to larger centers? Because now we use proteomics and mass spectrometry as the golden standard for the diagnosis of amyloidosis. The rationale is that when you apply these proteomic methods to amyloid typing, you have relative abundance of this amyloid protein in the tissue, and hence you can reliably detect this type of protein. Not only for the types of proteins which we know, but also this is how we detect newer amyloid protein, and this is the principal application of mass spectrometry. This is from our study, which Professor Mohammed Azizi have shown in his presentation, and this is how mass spectrometry works, and together with the identification of the main protein, which in this case was leukocyte ALAC2 amyloidosis, you can also detect serum amyloid P component, apolipoprotein E, and apolipoprotein A4, and these 3 are what we call the phenotype of amyloid. This is what tells you that this type of protein is amyloid. Then we measure the most abundant type of protein, and this is the type of amyloidosis. So you identify that this is an amyloidogenic protein first by these 3 molecules, and then you see the protein type. As you've heard enough about AL-amyloid, that this is a life-threatening form. And what's reported in the literature is that the median age of diagnosis is 63, and that more than 90% of patients are diagnosed above the age of 50. However, in Egypt and in our population, we do have patients as early as 30 years old and 34 years old who presented with AL-amyloid. You all know that it can be caused by monoclonal plasma cell clone, but other B-cell disorders which can also produce monoclonal proteins, as lymphoplasmacytic lymphoma, MALT, and CLL, will also can give you also AL amyloidosis, although much rarer. This is it's a rapid progressive disease because actually the light chains, as Tamer have mentioned, these amyloidogenic light chains have an increased toxicity compared to other types of amyloidosis, even at the lower concentration when compared at other types of amyloid fibrils. So this is a disease with a poor prognosis and a progressive organ damage. This is how amyloidosis would look like under the microscope. This is a PES stain, and amyloid is PES negative or periodic acid Schiff. This is again Congo red. This is the immunophenotyping. This is Lunda, and this, as you can see, it nicely stains. The positive is the brown. This is amyloidosis in a small arteriole, and again this is kappa staining for AL amyloidosis. And as mentioned, AL amyloidosis is more than 75% of cases is usually lambda more than kappa. This is AL under EM. I call it the tricky amyloidosis, especially this type of amyloid, because first it has varied presentations, which leads to delays in diagnosis. It can be very subtle in early cases, so it's one of the most missed types of amyloid. Sometimes it does not come alone. It's associated with other light chain or monoclonal gammopathy pathologies like light chain disease, like MIDD. So again, it's missed. Its presence is missed because it's not looked for. It's not always an isolated renal disease. It can come in association with other renal diseases as diabetic nephropathy, as hypertensive nephropathy. Again, could be missed, and this makes it a lot of difference because it influences the patient management and prognosis. And now, this is a normal glomerulus, or what looks like a normal glomerulus from a patient with normal proteinuric patient, and you don't see any types of what we have seen, all the pictures of amyloidosis, but let me show you. This is AL amyloid on higher magnification, and this is with the Congo red, and this is how early and subtle AL amyloid can present. It typically forms what we call AL spicules within the basement membrane. You can hardly see it within the glomerulus, and this is what the AL spicules presents with. This is what we call AL spicules by electron microscopy, and it is characteristic of AL amyloid. Again, very rare and very early AL amyloid deposits within the kidney. These patients are misdiagnosed as minimal change disease, and their AL amyloid is usually missed. As I said, it can come superimposed on other important or advanced chronic kidney disease as diabetic nephropathy, and this is an example of an AL patient who had kappa amyloid on top of diabetic nephropathy. Although bone marrow is listed as one of the organs where you can detect amyloid, let me tell you, it's not common at all. It's very uncommon to actually see abundant amyloid deposits within bone marrow, and usually when the patients get to this stage, you do have amyloidosis in other more readily accessible and less invasive organs. Lymph nodes also can be involved. Again, this is the case of AL amyloidosis in the lymph nodes. However, again, they are not common, and the majority of cases are involved in AL. There is a considerable overlap between AL and myeloma. We've mentioned, and I'm sure you know much better than me, that the medial clonal marroplasma cell percentage is 10%, and this is the same threshold for the consensus diagnosis of multiple myeloma. And as was mentioned, it usually ranges in AL amyloidosis from 7% to 15%. However, most of these patients do not have what we consider an active myeloma phenotype, which is defined by the CRAB features, and it's almost approximately present only in 10% of patients at the time of diagnosis. However, it correlates with the bone marrow plasma clone, and the higher the bone marrow plasma clone we have, the more expected myeloma phenotype you're going to see within this patient. So the overlap between this myeloma and amyloidosis should be a factor which is considered, because we know that patients with AL amyloidosis have a poorer tolerability to immunosuppression. The important point is that you can have incidental amyloid deposits in myeloma patients in marrow or fat tissue, or even like this this is a cast which is all consisting of AL amyloid, and it gives this nice green birefringence under polarized light. However, this is not equivalent to AL amyloid, so this should not influence the decision of management or therapy for AL amyloidosis. Some patients which usually have late diagnosis, as I mentioned, could have more than one light chain related pathology in their kidneys. AL amyloid, a light chain, as you can see, this is a cast nephropathy, and all what's surrounding it is actually AL amyloid. Okay, I'll skip the MGRS for the sake of time, and I'll just come to our studies, and this is our single center study. This comes from our lab, a Path lab, and this is a renal native biopsies studies from 2012 to 2020. This is almost 10,000 biopsies, and amyloidosis, the diagnosis of amyloid represents 6 to 7% of this diagnosis. This is not a rare disease. We started with the study again of the LECT, which Professor Mohammed have shown, and in this study, it was 116 cases, and our target actually was the identification of LECT amyloidosis in Egypt. And so we more or less, these were not randomly selected cases, but even in this initial case series, you can see that AL comprised 20%. When we increased our case series to 364 cases of amyloidosis, AL now formed around 25%, and finally, up to today, we have 611 additional amyloid cases, and AL amyloid comprised 25% of the number of amyloidosis, same as ALECT2. 2, same as leukocyte chemotactic factor, and this is the main differential diagnosis with AL amyloid, because it's not, if it's not typed and it's not identified, it's mistaken as AL amyloidosis, and patients receive unnecessary treatment. It is much more common in our population than hereditary types of amyloidosis, and as you can see in our series, unphenotyped cases, which would represent the hereditary types of amyloidosis, were presented around only 2%. So most of our cases were typed by the commercially available immunohistochemical staining. Less than 5% were sent for mass spectrometry. Mass spectrometry is not available worldwide. It's available only in few centers. So to sum up, AL amyloid ranks second in Egyptian patients, same as ALACT, and comes and follows AA. It can be underdiagnosed due to its early, subtle, and variable presentations, and requires expertise in its diagnosis. As Tamer have mentioned, the presence of monoclonal gammopathy in a patient with systemic amyloidosis does not prove light chain type. NGOS is not uncommonly coexists with non-AL systemic amyloidosis, and you've seen the reports, so accurate typing will avoid such mistakes, especially with LACT. We have several cases where patients have an MGUS, but actually their amyloid type turned to be LACT. Mass spectrometry can detect uncommon or novel types, and its sensitivity is close to 100%, making it the gold standard for diagnosis. However, it's an expensive typing method, requires specialized lab equipment, and is not widely available worldwide. So we have the availability to use the antigen antibody-based timing methods. They are accepted, and this type of diagnosis, the MS, can be researched for typing when other methods have failed or are inconclusive. Finally, I just would like to leave you with a message that amyloidosis is not a rare disease. Thank you very much.